May I start, sir?
Yeah, yes.
This is a talk for organization of ECPR program. Probably this is one of the most difficult tasks for any kind of ECMO program, whether it's existing or it's a newly formed or people have started ECMO programs, and the calls for ECPR comes on. So whether to do and how to do a sustainable ECPR program, I'll try to highlight on that. Starting with a case, I know that is a basic thing. What we're doing is an VA ECMO when we are putting during CPR, that is the ECPR. Now, obviously, it is a VA ECMO. Sometimes 5% cases VV ECMO can be put in kind of status asthmaticus with hemodynamic instability. You can put VV ECMO in near arrest situations. But 95% time it is a veno-arterial ECMO, ECPR means. Now, ECPR is nothing but the rapid deployment of veno-arterial ECMO to provide circulatory support in patients in whom conventional CPR is unsuccessful in achieving the ROSC. So this is the definition of ECPR. Now, every point is important, that rapid deployment. You know, we do VA ECMO, but sometimes we get time. This time we don't have time, rapid deployment. Another is to provide circulatory support. Third one is that if your conventional CPR is unsuccessful, so you have to continue the conventional CPR and ROSC is your target. Now, I'll just start with a case. She is a case of a 57-year-old diabetic female who came to visit OPD with orthopnea for 3 days and fever since 1 day. In the OPD, she had a cardiac arrest. CPR initiated, called for assistance, and shifted to emergency. Now, intubated, ventilated, taken on inotrope, somehow the ROSC achieved. So this is the scenario. And again, she started having VFib, CPR restarted, DC cardioversion done, ROSC achieved. So in between, she had recurrent VT, TPI inserted, but it's a coming and going rhythm. So the ECMO team has been called in the emergency, and this is the thing. If you can see the video, this is the LV, which is in between kind of thing. What is there in between arrest? You get this kind of LV. So it's dilated and it is getting recurrent arrests. Now, the rescue is possible. Now, what we do actually, the American Heart Association has given an update of this grade of 2A with the use of ECPR with arrest refractory to standard CPR, reasonable to select patients when provided in appropriately trained and equipped system of care. So with that thing, extracorporeal CPR, we put this patient on ECMO with the ongoing conventional CPR intermittently, because this patient was having recurrent cardiac arrest, recurrent VF, and we are giving shocks, and in between started doing cannulation. Now, this was the ABG, obviously very high lactate, very high, your pH is not maintaining, and this is the X-ray. You can see bilateral severe pulmonary edema with froths coming out of the tube. And this is the scenario. If you can see what is the scenario happens. Continuously, somebody is doing CPR and you are trying to cannulate, and in between, at your convenience, sometimes 1 or 2 beats can be missed, so that you can push the guide wire in and do the percutaneous cannulation. So this is a classical scenario of an ECPR going on in this kind of patients. And this is the thing which happens in our unit. Everybody is, I think, very familiar with this kind of situation, if you see this. So it's not easy to organize this kind of event when there is a CPR or a cardiac arrest happened, and the continuation of CPR during the cannulation, what you are doing. I think the previous speakers have told how to do the cannulations, and a lot of people are assisting here, at least 5-6 people around. The nurses who are giving heparin, somebody is giving adrenaline to maintain some kind of circulation, and continuously doing CPR, somebody with the changing hands. So this is the scenario. is a classical ECPR going on, and somebody is cannulating and priming the pump, so that once it is the cannulation done, you can connect to the ECMO. And with the cannulations, you can give with that thing, the CPR going on. So you cannot stop the CPR. CPR has to go on at any point of time. So after that task, we successfully put the patient on ECMO, and the ROC achieved. And this is the X-ray after, say, 48 hours with the correction of acidosis, with the lactate came to 6.3, coming from 10, and started having some kind of ejections, the saturation of 72. But we managed with PEEP and the management of pulmonary edema with ventilatory adjustments. We get some out the flow, and some amount of pulsatile blood flow is going on. EC changes are still there. The day by day, after third, fourth, fifth day, it has started improving. You'll see the heart is the EC changes are less frequent, and you're getting a good saturation with the good pressures. And you can see the SGOT, SGPT is very higher side, is coming down. The creatinine is coming down. And if you can see the LV started improving, the X-ray started improving, and the heart is improving overall on ECMO. Now, on the day 6, you come down on flow from 2.37 to 0.82, stayed on idle flow. And this is the monitor when you were trial off with a lactate of 1.29. And you call the surgeon to take out the cannulas, because at hurry, you have put the cannulas, the punctures are high up. So it is better to call the surgeon and just take out surgically. Now, what happens? This kind of arrest happen and CPR is going on. So we recommend for anybody who is trying to do ECPR, establish a clean single puncture femoral arterial access as soon as the ROC achieved in between. If you get some kind of pulse, or if you are not getting some kind of, it is the first thing, because you will get the veins, but you will not get the arteries. So whenever there is a chance in between some kind of ROC happened, or shock, you are giving shock, some kind of rhythm came, just put an arterial line in one groin. So that is the thing that will help you to put the arterial catheter or the arterial cannula by railroading. And this is where your ECPR success is there, because it is easier to get the venous line, but it is not easier to get the arterial one. And if your institution is ECMO center, then always go for a ECMO referral and urgent escalation, like what we have done. If it's not an ECMO center, so it will be a conservative management. Now, what are we expecting when we do the ECPRs, this kind of situation? We don't know what will happen, but expect the hypoperfusion, different hypoperfusion issues like tissue injury, hyperlactatemia, organ dysfunction, and deranged parameters. And coming to the next main part of my core topic is the cost, cause, cannulation, and continuity. Whether it's feasible or not, who will bear the cost? What is the cause of the cardiac arrest, whether it's reversible or something he has previously, heart is bad and he has arrested, you don't know whether this will help it or not. Cannulation, how we have done the cannulation, open cannulation, surgical cannulation, we'll open the chest, what we have done, and continuity, whether to continue on it or not. And looking at this kind of success stories, the people will start doing ECPR slowly, but you have to keep in mind these considerations. Now, a lot of publications has given that percutaneous Seldinger with EVSG is the ideal technique where you should do an ECPR, because always the surgical help is not there in our context, and you need to learn how do you cannulate at that point of time. Now, a lot of trials like arrest, Prague-Whitney, inception, a lot of time has given distributed what are the time in the scene, transportation, cannulation, and total low flow time that you have to take in control for the success of the. And what is the distance from that OHCA, the out of hospital cardiac arrest from your hospital. Now, you can decrease the minimized time in the scene, transport, and then cannulate in your center, or you decide to cannulate on site. You are prepared, you went there, you cannulated, your transportation time is no transportation, you have cannulated. So you reduce the transportation time so that your low flow time decreases. Or at initiation at the hospital, bring the patient, and then the transportation time actually, at least 20 minutes of transportation time to add on. So it increases the low flow time, the chance of outcome goes down. So you have to keep in mind that whether you are ready for the HCA kind of thing, and if you're ready, whether you will go and cannulate or bring the patient to your facility and then cannulate or not. So this is to be understand the very frequent. And what are the things for HCA, out of hospital cardiac arrest? There is the patient selection. Obviously, a lot of criteria, less than 75, the good bystander CPR received, shockable rhythm, short low flow duration, incomplete information, professional CPR team is there or not, availability of ECPR resources. Logistics, obviously integration of the ECMO center, where to cannulate, whether we'll bring that thing or go on site. If it happens in ICU, the trained staff, bleeding, transfusions, who is going to manage it, the thrombosis, 24/7 availability and demand, ethical dilemma frequent. So care is to stress the team, and neuroprognostication, that is one thing. The how is will be the brain, we don't know. Complications, can't cannulate. That is that can happen because the most common thing is artery. You are not getting artery. CPR associated trauma. You have pericardial effusion. You have broken ribs. You have pneumothorax. It can happen. Leg ischemia. You could not cannulate the distal perfusion, or you didn't at all try it, and the leg got ischemic. Bleeding, obviously, and availability of ECPR resources, transition at minute, and preclinical integration of ECPR. So these are the ECPR transition. So these are the things we have to take in mind. And a established ECMO center should start ECPR with keeping all these things in mind, starting from patient selection, logistics, what will happen in ICU, what are the ethical dilemmas you can face, complications, ECPR transition. So not all patients are going to give ECPR. Some patients you just say, I will not give ECPR to a more than 50 years of age, or I will not give ECPR whoever is coming to emergency. I will restrict my ECPR in the cath lab, or I will restrict my ECPR in the operation theater, or I will restrict my ECPR in the cardiopulmonary ICU. So you can frame your program as per your capability and as per your need, because nobody is telling you to start ECPR program in a bigger way, so that the day one you start, whoever is coming, then cardiac arrest, reaching to your emergency and do ECPR. So you have to very much readiness has to be as your capability is. Now, all of us, we know that what is the rationale of ECPR is obviously the conventional CPR gives 50 to 25% normal cardiac with low flow state, and with the ECPR we can go to the good flow and good the organ function will come up. Now, 4 distinct criteria for ECPR is a 0 to 5 minute startup ECPR, witness CPR, bystander CPR, shockable rhythm, or no major comorbidity. Who is going to tell this? So this is one of the part where your outcome of the ECPR managed. Now, notify the ECMO team that you had to call the ECMO team that the conventional CPR is going on, but we are not getting ROSC, or immediate transfer to ECPR capable hospital. Whether you go on site or you transfer them. Attempt to go on ECMO flows, the cannulation, establishment of ECMO support, and insertion of distal perfusion catheter. I will not recommend you to put distal perfusion catheter at any kind of ECPR situations at that point of time. It will take a lot of time, but patient might not survive at that point of time. Immediate investigation treatment of suspected cause of arrest. After putting the patient on ECMO, you have to take the cath lab. And next is your post-arrest care. How do you monitor these things? Now, arrest to ECMO flow time aim should be less than 60 minutes. So low flow time and no flow time, total thing should not cross more than 60 minutes. It is better to keep less than 45 minutes. I don't know whether it's possible for us in OHCA, but even in the in-hospital cardiac arrest, if it is in the ICU, if it's in the cath lab or in the operation theater, some kind of thing happens, you can reduce your timing to 45 minutes. And here actually the ECPR program survival and the outcome depends. Now, this is a very important slide. Lot of questions been asked that whom I am going to do the cannulations. How do I know this patient is going will not achieve ROSC even after CPR? So, and how long we will continue to do CPR and not to put ECMO? So, anticipating the risk of the cardiac arrest and appreciating an evolving low cardiac output state with impaired oxygen delivery requiring escalation of care should trigger the discussion of pre-arrest ECMO support. Whenever this patient is not doing well with some amount of rhythm in between and some amount of pressures, which is low pressure with a lot of antibiotics, but there is always a chance of this patient getting cardiac arrest. This is the time where we should be prepared. And this is the pre-arrest ECMO support in a hemodynamically unstable patient is better than after the cardiac arrest occurred. And deploy the ECMO during acute CPR. Here, it is very much common in the in-hospital cardiac arrest. The patient not doing well, severe low cardiac output state, there is a chance of getting cardiac arrest. At that point in time, you should be ready. And if you are in cardiac arrest, you just putting the patient on ECMO. So this is the time where the patient is in low flow state, pre-CPR, and if the cardiac arrest happen, you are not actually you are not losing any time. Now, criteria. You can frame your criteria of your institute for consideration of ECPR. Witness cardiac arrest, obviously, I recommend for that. Initial shockable rhythm, although subgroups of non-shockable rhythm has shown good outcome, but shockable rhythm is always a very good. VFib and VTAC, most acceptable. Performing good quality of CPR, that you have to ensure. Obviously not extremes of age, because a lot of problem happens in smaller babies and obviously in the older age group. Favorable prognostication markers, low flow time being less than 30 minutes, where the ECRS team is called, potential organ donor. And background disease consideration that this patient is having an organ dysfunction or a carcinoma patient, poor quality of life previously, or with a pediatric chromosomal abnormality. So you have to select under these 6 parameters that this is the patient where I'm going to do an ECPR. Otherwise, I just cancel the ECPR. Now, protocols and pre-definition. These are the another thing we have to go for this thing. But most commonly, decision is making pathways and flow charts. Role defining. Who is going to do what? Who is going to do the CPR? Who is cannulate? Who will prime the pump? And what and where I am going to do this. Site, technique, location of cannulation. Predefining patient groups and subgroups, that I'm not going to do ECPR in more than 50 years of age in my hospital. Or even the choice of if CPR should be managed. And a good quality CPR en route, even if the transport, even if you're bringing the patient from the other side to your hospital, a good quality CPR should be continued till it reaches the familiar location. Now, maintenance of adequacy of quality of CPR sometimes is very much manpower dependent. So there is a better use of Lucas device, though I have not used in my hospital. We are still dependent on the bystander, the nurses, the paramedics, the doctors, whoever is there to start the CPR. Or initiating ECMO cannulation, the initiation of CPR, you are not transporting this patient, even you are not intra-hospital transport is not allowed. Where the arrest happen, you put the patient on ECMO. Now, you need an adequately trained transport team, role defining, probably a code ECMO should be announced, and then you just rush into this role defining team, more frequent mock drill, alertness, ready to mobilize at the moment's notice. So these are the things for like a code blue team, you need to have a code ECMO team to have a successful ECPR program. Access, it should be predetermined. Adult patient, I'm going to put the cannula in the groin. In pediatric, I'm going to put the cannula in the neck. So, and if a surgeon team is there, you will go for a cut down, or if not a surgeon team is there, I'll go for a percutaneous. Whenever possible, I'll put an arterial line so that I can pre-dilate and put the cannula. Default cannulation approaches that lesser than 10-15 kg rapidly cannulated by carotid. So you need a surgeon for if your pediatric program is robust and it has to be cannulated surgically. But a 50 kg adolescent will be cannulated by femoral. So you have a predetermined approach that this patient, if this kind of patient comes, through which you are and you cannulate the most common way of cannulation, what you do regularly. So that will give you the success. Equipmentation. Now, you need to have your cannulas it has to be ready. Size defined by the BSA and by requisite cardiac output. Now, readiness and availability of the cannulas, each side to this thing should be there, and somebody is there to give it to you at that point of cannulation. You use the ETO sterilized reuse cannulas for uncertainties of patient outcome or to reduce the cost, but it is not easy to insert sometimes these reusable cannulas. You can use the newer cannulas. Can consider the roller pumps, handmade circuits, smaller oxygenator, CPB oxygenator if the finance is an issue. So you prime the pump with your CPB oxygenator that costs around 20,000. So totally, it will not cost more than 25,000. You take the patient on ECMO after doing ECPR. Then the patient is waking up and all these things, change it to the ECMO oxygenator. That you can do. That provision should be kept at your hospital if you are if you form the SOP. And you should have a fluid primed circuit as a standby. You see my video where somebody is priming the circuit. That time can be minimized by if you have a primed circuit. And any primed circuit can be kept for 30 days and before disposal. So you can keep it. You can keep a primed circuit at cath lab. You can keep a primed circuit with the operation theater or in the any kind of ICU or ECMO ICU where you just rush in and just cannulate and take the patient on ECMO. So these are the prerequisites, equipments. And obviously, always do not wait for the blood to come because you can go on bypass. Adult patient is not very easy. It's very easy to go on bypass without your blood priming. In pediatric patients, obviously, you can give the blood later on. You can take out the fluid out, but don't wait for the blood for your CPR, ECPR to happen because that will take a lot of time for blood to come to that place of where the ECPR is going on. Now, aftermath. This is another thing we have to learn that obviously the myocardial recovery, critical questions, electrical activity is there, limited ejections, the heart is getting dilated. So you should have a venting strategy. So these are the immediate issues happen. So venting strategy. Last 2 days back, we did an ECPR, which actually it was a very successful ECPR. We did almost 35 minutes of cardiac arrest. We put the patient on cannula and all this, but after 4 hours, it has started. LV started dilating, and we could not take any kind of venting measures other than IABP, and the patient died. So, adequate venting strategy in all forms, percutaneous or any kind of your thoracotomy strategies or opening of the heart, whatever you want. Impella, VADs are very much costly, but you have to have this IABP at least to get this LV venting strategies. Bleeding, you have to control the bleeding. You need to have a surgical colleague in your team because during cannulation, you might injure the vessels and they are your saviors. Temperature therapy, debatable. Personally, I don't do this. I come down to 34 because a lot of arrhythmias happen at that point of time. I'm afraid of getting the temperature down. Poor neurological outcome has to be considered. If the patient is not getting away within 48 hours of successful ECPR, that means you have to go for an imaging or maybe prognostication. Now, this is my last slide. Now, we do start ECPRs in our programs, but whether we can continue it, all of us has done probably 15, 20 ECPRs with some amount of success rates. We speak about those success rates in the public forums, in the conferences, but maintaining an ECPR program over and over time, years and years is very difficult. So what should be done for that? I don't have much answer because obviously in my center, I could not start the out-of-hospital cardiac arrest. It's purely dependent on in-hospital cardiac arrest, and that to a very predefined areas like ICUs, like cath lab, like operation theaters. So still, we have to learn from our big brothers whether how this out of hospital cardiac arrest program or ECPR program will be maintained rather than doing some anecdotal cases. Now, get associated with the established registries. You will learn from that. Administrative strata regarding need for ECPR program, you have to tell them. You have to tell them that your management, the value is in lives, not in the return of investment. Identify the key stakeholders, build a team with the people who are actually with you regular basis. Who is doing regular ECMO can only do ECPR, because that is the thing, nothing but a rapid deployment of VA ECMO at the time of cardiac arrest or ongoing CPR. And you have to do drills, you have to do mock runs, the daily rounds and monthly meeting, obviously, how it is happening, what we have done in my last thing, how the patient could not make it, and what are the things we need to improve. It has to be a regular thing, apart from your daily ECMO patients. So I think I could answer the few things, but still it's very incomplete presentation from my side. Probably in coming days, I can improve my things with number of cases when it goes up, and I can share with you how ECPR program is running in our hospital. Thank you, sir. Over to you, Pranay, sir.